our insert group, it is very gratifying to share with you our 4th International Virtual Symposium on Fertility and Assisted Reproduction. Today, I'm going to talk to you about the tubal pathology, especially tubal localization by laparoscopy. First of all, it's important to remember that 35% of infertility in couples is attributable to female factors. Tubal fertility affects approximately 20% of women. The problem is blockage, damage, and malfunction and damage of the tubes. The cause of this is pelvic inflammatory disease, endometriosis. Previous pelvic surgery like ectopics, for example, or planning methods, and sexually transmitted infections. The tubal sterilization is currently the most popular form of birth control. Female sterilization represents 30% of all contraceptive methods used, in equal to 200 million women in the world. There are different surgical techniques for sterilization. It's important to remember the different parts of the tubes: the interstitial, the isthmus, ampulla, infundibulus, and fimbria. There are different techniques to do a sterilization by laparotomy, like Pomeroy, Parkland, Irving, Uchida, Kroner, is myectomy, or salpingectomy. By laparoscopy, we can do a sterilization about the techniques of Pomeroy, Filchi clips, John ring, Hulka clips, Kroner, myectomy, or salpingectomy. In women that are less than 30 years old, the probability to present regret is 20%. 14.3% were seeking advice on methods to achieve a new pregnancy. Between 2-4% made the decision of a reversal method or an assisted reproduction technique. It's different in women that are more than 30 years old, that 60% present regret, 60% were seeking advice on methods to achieve a new pregnancy, and 0.2% made the decision of a reversal method or an assisted reproduction technique. 14 years cumulative probability of requiring reversal information depends on the age of the woman decide to do a tubal sterilization. It's like women from 18 to 24 years old, 40% requiring reversal information. In women between 20 and 30 years old, it's 50%. In women between 31 to 35 years old is 8%, and women over 35 years old is 4%. Women aged between 18 and 24 years old at the same of sterilization have 3.5 times more likely to request reversal information than those over 30 years old. Tubal ligation during an emergency cesarean section is associated with a 3-fold increased risk of regret and information seeking when compared to an interval delay ovulation. The first tubal laparotomy anastomosis was performed in 1896. When the different techniques are evolution, like microsurgery, laparoscopy, and robotic surgery accompanied by adequate tissue management, use of non-adhesive device, and use of antibiotics allow development of safe and effective tubal localization. The current surgical technique for tubal localization is laparoscopic surgery. There are very many advantages like minimal tissue manipulation, less postoperative admissions, short duration of postoperative stay, less pain postoperative, less bleeding, and more aesthetic. There are many indications for reconstructive tubal surgery. For example, in the ligation, the irreversible surgical sterilization is the first indication. In the case of isthmic salpingitis nodules that you can see in this picture, is another indication for reconstructive tubal surgery localization. In the case of ectopic pregnancy, the best way is salpingostomy. In case of tubal adhesion and distal tubal obstruction, The best way to do a reconstructive tubal surgery is by neosalpingostomy and fibroplasty. In some cases, the patient asks about to be at peace of mind and with your body. The other indication is no acceptance of ART for religious beliefs, for non-acceptance of frozen embryos and its subsequent implications for a live birth in the fate of safe embryos, increased risk of prenatal morbidity with ART, like preterm birth, gestational diabetes, abnormal presentation of preeclampsia, risk of ovarian hyperstimulation syndrome with AVF, or no wanting multiple pregnancy. And finally, the economic factor that limits access to assisted reproduction techniques. This systematic review evaluates the effectiveness and risk of complications of different surgical techniques for the reversal of female stimulation compared with AVF. This review includes 37 studies. The results are with anastomosis by macrosurgical laparotomy have a pregnancy rate 42%. The risk of ectopic pregnancy is 80%. With anastomosis by macrosurgical laparotomy, the pregnancy rate is 68%, and the ectopic pregnancy is 10%. In the case of laparoscopic anastomosis, the pregnancy rate is 65%, and the ectopic pregnancy is 5%. And in the case of robotic anastomosis, the pregnancy rate is 65%, and ectopic pregnancy rate is 50%. You can see when you use a microsurgical, laparoscopic, and robotic, it's very similar to the pregnancy rate and the risk of ectopic pregnancy. When you do a comparison about the anastomosis by laparoscopy versus laparoscopy, is no difference in overall pregnancy rates. Ectopic pregnancy, no time for surgery to pregnancy, between 6.5 months. Surgical time is longer in laparoscopy. The total cost is higher with laparotomy, and the medical training is measured with laparoscopy. The comparison with laparotomy anastomosis with microsurgery versus laparoscopy versus robotic surgery, no difference in pregnancy rates. Robotic tubal anastomosis versus laparotomy microsurgery, pregnancy rate is no different. Ectopic pregnancy in two studies analyzed with opposite results, one greater risk with robotic surgery and another without showing difference. Surgical time, shorter with laparotomy. Duration of hospitalization, no difference seen. Use of analgesics is higher in the laparotomy group, and the cost is higher with robotic surgery. The comparison with laparoscopy versus robotic surgery, no significant difference in pregnancy rate, ectopic pregnancy, or hospital stay. Greater surgical time in the robotic work versus laparoscopy work. And the comparison with tubal anastomosis versus AVF is different depends on the age of the women. In women under 37 years age, tubal anastomosis have the delivery rate 72%. AVF, the rate is 52%. In women that are over 37 years old, is different. The AVF is higher, 51%, and tubal anastomosis is 36%. With modern minimal invasive approach, you can expect pregnancy rates like this. In women from 18 to 30 years old is 73%. In women between 30 to 33 years old is 64%. And in women from 34 to 39 years old is 46%. The result of this systematic review is the full pregnancy rate after sterilization reversal was between 42% and 69%. Reported ectopic pregnancy rate was 4 to 8%. The only prognostic factor that affected only to conception was the human age. The comparison between laparotomy, microsurgery, laparoscopic, and robotic surgery showed no difference in pregnancy rates. And for the women, AVF could be a more cost-effective alternative to surgical reversal of sterilization. This study is to try to show what is the principal request in sterilization reversal. In this study, death of one of the children was 65%, second marriage is 27%, and disability of one or more children is 7%. So in our clinics right now, the first reason to requiring sterilization reversal is second marriage. The mean interval between recanalization and pregnancy was 6.5 months. In case with sterilization by the Pomeroy method, 40% conceived. In case of laparoscopic tubal ligation, 85% conceived. And none of the patients with final tubal length less than 5 centimeters conceived. So we can do recommendations to achieve success in tubal localization. The first one is age under 37 years old, no presence of other pathologies associated with female infertility, like endometriosis, addition, adequate coital frequency, 1 to 2 times per week, adequate ovarian reserve, ligation performed with a ring or clip by laparoscopy is better, BMI less than 25, spermogram of the normal partner, post-anastomosis tubal length more than 6.5 centimeters, and it's better when it's performed by surgeons specializing in reproductive medicine. An additional aspect to have in mind is factors such as the time after the tubal ligation was performed and the location of anastomosis have not shown difference in fertility results. Analysis of prognosis factor for ectopic pregnancy limited. There was no correlation between the possible anastomosis sites and the percentage of ectopic pregnancy. Or isthmus, or ampulla, isthmus, ampulla, ampulla. Although there was a slightly lower incidence in the isthmus anastomosis. 3 to 5 stitch initial layer is optimal to maximize patency and postoperative pregnancy rate. Another study recommends using 4 stitch in each layer to obtain successful results in terms of tubal patency and pregnancy rate. But the real important is of meticulous technique and presence alignment of tubal segment, independent of the number of the stitch. Today, there are no studies that compare the use with no use of intraluminal tubal stents for performing tubal anastomosis or the possible potential for damage to the tubal mucosa and its subsequent impact on the pregnancy rate. However, some studies support the use of a stent to possibly facilitate the surgical technique to improve tubal patency and potentially increasing pregnancy rate. However, current evidence is inconclusive. There are many surgical tips. So right now we can see a video of the laparoscopic tubal localization. Infiltrating the mesosalpinx, good stones, distal, section of the scarf, previously scarf. This case was a young ring. Good stone, proximal stone, and identify the pathology of the proximal tube. Okay. Identify the mucosa. Selective hemostasia with bipolar in loop patency. It's important to go in the mucosa to allow a better augmentation of the stumps. It's very important to get a good alignment of the both ends, the both stumps. Hold the suture softly and cut the suture short the knot. Check the spill on the tube to avoid it, and do a new suture to avoid spill. To hold the suture with the holder of the needle, it's very important that it's soft to avoid blocking the suture. And when you pull the suture, it's important to do it soft to avoid diminish the suture. Introduce the mucosa is very important in this point. To check the potency of the tube, close the serosa with the same suture, and it's very important to remove the suture by holding it by the needle to avoid loss the needle in the cavity. Introduce the suture with a 5mm needle holder, as shown in the video. Through the trocar for 5mm. Check the anastomosis. And for release retention of the anastomosis, it's important to do a suture with bicoil in the mesosalpinx. This is the contrary tubes, the anesthesia. The section of the mesosalpinx is important to allow adequate visualization of the interproximal tube. Such case we can use a pitocin to hemostasis to avoid electricity. Again, remove the needle, holding it in this way. Release, in this case, the mesosalpinx using bicoil. And finally, we use a Guardix, like if sodium hyaluron, to avoid adhesions after the surgery. So thank you very much for your time and for your attention. I hope to see you again soon. Thank you.